A very good afternoon to all the distinguished dignitaries. I'm Dr. Anshita Agarwal. I extend a very warm welcome to all of you to the first session of Day 1 of SPEEDCON 2022, where the emphasis would be on closing the loop on endocrine enigmas. I promise you that the next 2 days or so are going to be an absolute academic feast, where we'll be learning and getting to know lots of new things, and by the time we finish this conference, we'll definitely be much more enlightened. So without much further ado, I would like to kickstart the first session. We are beginning with the Meet the Professor session, and for the first panel on the Meet the Professor, the topic for which is type 2 diabetes and grade 2 fatty liver with raised transaminases. I would like to invite on the stage our respected moderator, Dr. Jaiwant Rangi, who's MD, FASC, consultant at the California Anti-Aging and Wellness Medicine. Ma'am has numerous accolades to her credit, as we can see here. We extend a warm welcome to you, ma'am. Now I'd like to request the experts for this session to please join us on the stage. I would welcome Dr. Khalid J. Faruqi. Sir is MBBS, MD, DM Endocrinology and a Senior Consultant of Endocrinology and Diabetes. Sir, we extend a warm welcome to you. The next expert for this session is Dr. Rohit Goyal. Sir is MBBS, MD and DM Gastroenterology. Sir, extending a warm welcome to you as well. Now I'd like to hand over the stage to our respected moderator to start today's session. Thank you.
Hello everyone. My name is Jaiwant Rangi. I went to medical school in Lady Harding Medical College back 25 years ago. I've been practicing in California now for the last 20 plus years after doing my residency and fellowship from Wayne State University, Detroit, Michigan. It's an honor to be here, and I'm delighted to be on this stage with my esteemed colleagues. Without any further ado, I don't want to take any more time because we have very interesting discussion. We will go over a few slides just to have introduction to the topic, and then we'll go over the case so we can have a good discussion with our panelists here. So just to go with the definitions of NAFLD and NAFL and NASH, it's an umbrella term that includes NAFLD has NAFL, NASH, and hepatocellular carcinoma all under the umbrella. We commonly use NASH as one of the commonly used names to replace NAFLD. But just to give you a background, not everybody with NAFLD has NASH. NAFL is pure steatosis without any hepatocyte damage. And with NASH, you do have some fibrosis as well. And depending on the degree of the fibrosis, we call it early or late stages. NAFLD is associated with major cardiovascular risk factors, including type 2 diabetes, obesity, dyslipidemia, hypertension, insulin resistance, and metabolic syndrome. The association of metabolic syndrome and NAFLD is so strong that NAFLD is considered as an hepatic manifestation of metabolic syndrome. The clinical implication of NAFLD and non-alcoholic steatohepatitis, or NASH, are mainly derived from their common occurrence in the general population of about 25% and the potential to contribute to coronary artery disease, extrahepatic cancer, diabetes, progression to fibrosis, cirrhosis, and HCC. Although the mechanism of underlying liver disease progression remains unclear, the insulin resistance and obesity, related inflammation, and ectopic fat and lipotoxicity play a key role, along with the possible genetic, dietary, and lifestyle factors. NAFLD presents in 15 to 30%, as we mentioned. Prevalence is also high in overweight and obese children. Factors contributing to NAFLD include sedentary lifestyle, increased consumption of foods with high fat and high fructose corn syrup, which usually most commonly is in the soft drinks. Steatosis is associated with an increased prevalence and incidence of coronary artery disease and cardiovascular mortality. In addition to the most prevalent cause of liver disease, in the developed world, Second most common cause for end-stage liver disease, and that is alarming. I think that's where it brings our attention, and need for liver transplant in US and rest of the world. Predicted to become the most common indication for liver transplantation in the next decade. Third most common cause for hepatocellular carcinoma in US. Of course, there are multiple organs that are involved in NAFLD, which includes adipocytes, pancreas, gut, and liver. So here's a presentation, and after this, we're going to have some questions for Dr. Farooq and Dr. Rohit. It's a 52-year-old perimenopausal female with type 2 diabetes since the age of 40. She has a history of hypertension, stage 1 obesity, hyperlipidemia, and hypothyroidism. Past surgical history, she has had 2 C-sections at the age of 29 and 32, tonsillectomy in childhood. In review of symptoms, she has fatigue, bloating, constipation, mild anxiety, weight gain of 10 pounds in the last 2 years during COVID. I bet you're all seeing that, COVID weight gain, right? You're all seeing that? Yes, we are seeing tremendously in US as well. On an average, 10 pounds or so per year, 10 to 20. And just wait for all that to translate into new cases of diabetes. You know, all of us are going to be responsible to take care of those as well now. Social history, she's an accountant by profession, no history of alcohol use or smoking, no routine exercise, no tattoos, no recreational drug use, and she's heterosexual. Family history, she has significant family history for diabetes in mother and mother's side of the family. History of myocardial infarction, coronary artery disease, and angioplasty in father at the age of 62. Paternal grandfather had stroke at 80, both set of parents with hypertension and hyperlipidemia. Pretty much a very typical family history, right? We all come across this. In regards to treatment, patient was treated with metformin at the time of diagnosis, DPP-4 inhibitors added after the first 8 years. Thereafter, pioglitazone was added. On the current medication list, patient is treated with metformin, 500 milligram twice a day. She's unable to tolerate the higher dose because of severe GI side effects. Again, something very common, right? We all see that. Trulicity, 1.5 milligram weekly subcutaneous injection, and pioglitazone, 30 milligram once a day. On examination, it's a middle-aged, happy woman, no acute distress, blood pressure 140/90, pulse 80, afebrile, BMI of 32, and rest of the exam is unremarkable. So in regards to evaluation, the A1C is 8.2%, normal electrolytes, normal kidney function, mildly elevated transaminases, normal total bili, CBC within normal limits, TSH within normal limits. So in summary, this is a 52-year-old perimenopausal obese female with type 2 diabetes since the age of 40, so total duration of diabetes about 12 years, with an A1C of 8.2%, elevated transaminases, hypertension, hyperlipidemia, and hypothyroidism. So the most obvious abnormal findings that need attention include her obesity with a BMI of 32, A1C, and the elevated transaminases. So here begins the fun. So are you ready, the panelists? So what is the association of NAFLD with diabetes? Dr. Farooqi, I think I'll start with you.
Good afternoon. So we know that both these things coexist with each other, and individual with NAFLD is at a higher risk of developing type 2 diabetes, and person with type 2 diabetes mellitus is again at a high risk of having non-alcoholic fatty liver disease. So because of obviously the shared risk factors, so all the factors contributing to metabolic syndrome are in essence present in both these conditions. So that is one thing. Then usually, because obviously now we have realized that it's not a benign condition, and if we are able to diagnose this in the earlier stages, obviously we can take preventive steps and prevent this from progressing into stage 2 hepatitis and further complications.
Great, thank you. I have a question for Dr. Rohit. What's your take on, I'm sorry, not all the questions are up here, so we have some more questions we'll be going over. What is your take on NAFLD versus MAFLD?
Okay, so now the concept of MAFLD is emerging. So the latest guidelines by the Asia Pacific Consensus Committee, they use the term MAFLD. And what is MAFLD? It is metabolic associated fatty liver disease, which they define as presence of fatty liver with one of the following things, either obesity or diabetes or any evidence of metabolic syndrome. So if you have any one of these along with obesity, it is termed as MAFLD, which means that the patient is at risk of developing a liver disease and it is a positive diagnosis. So previously what we used to say was you can diagnose NAFLD if there is no history of alcohol. No. So now what people have realized is that people who do not take alcohol or who take alcohol, if they have a metabolic syndrome, then they are at a higher risk of complications compared to those who do not have a metabolic syndrome. And this is important. So people must realize that metabolic syndrome is an independent risk factor for adverse liver related outcomes and for liver related complications. And every patient who has a metabolic syndrome has to be more carefully evaluated and treated. The outcomes of other liver diseases like alcoholic hepatitis, alcoholic liver disease are again worse in people who have associated metabolic syndrome. So progression of HBV, HCV and alcoholic liver diseases is also faster and the risk of cirrhosis and SCC is higher in people who have a associated metabolic syndrome. So to emphasize this point, now more and more people are using the term MAFLD instead of NAFLD.
Thank you, Dr. Rohit. That was very eloquently presented. Is it fair to say that if you have underlying metabolic syndrome, then it's more like fueling the fire? So if you have any
Yes.
kind of condition that's going to be worsened.
That's right.
Great, thank you. When would you screen NAFLD patient in a diabetes patient? When would you screen for NAFLD?
So now there is no consensus, so different guidelines have different opinions. One thing is clear, that if a diabetic patient has abnormal LFTs, then he should be evaluated for presence of underlying liver disease. But a diabetic who has a normal ALT, the different guidelines differ. Asia Pacific guidelines say that yes, you should have a baseline screening. American guidelines do not recommend a screening ultrasound as a routine for all patients of diabetes. So diabetes with abnormal LFTs, definitely one should proceed to assess for fibrosis and other complications. Diabetes with normal ALT, it is a plus minus kind of thing. But generally the dictum is one should at least get a baseline ultrasound to screen for NAFLD.
Thank you. Dr. Farooqi, what do you think, at what point would you consider a referral to Dr. Rohit? If you have a diabetic patient with elevated transaminases, what are some of the conditions that make you concerned that now we should think about having a GI evaluation?
Right. So let's take the example of this case. So here we have a lady who has a moderately controlled diabetes with elevated liver enzymes and history of dyslipidemia. Now, whenever such patients present to us, obviously, as a background to what Dr. Rohit said, obviously just focusing on the AST, ALT levels, you might miss a lot of such patients, right? Because obviously, even patients with advanced fibrosis might have a normal AST, ALT levels. So obviously, other risk factors also need to be considered. Secondly, in the initial stages, even if the ALT-AST might be elevated, as the fibrosis advances, those numbers can become normal. So again, you might miss on severe disease. So in such a scenario, I would go for a non-invasive scoring methods, which basically involves use of platelet, AST, ALT levels, and the age. So most commonly that we use is a FIB4 score. The others are also available, for example, the non-alcoholic fatty liver fibrosis score, NFS score. Obviously, that has more number of inputs to be needed. So with simple CBC and LFT, you are able to generate a score which has a high predictive value or a high negative predictive value in ruling out advanced fibrosis. So if this value is less than 1.3, I would obviously continue with my diabetes management, try to optimize, make sure that the weight comes down, enforce the lifestyle modifications. If this score is more, obviously I'll move to the next step, and that would be most commonly I would go for a the measurement of the liver stiffness. So we commonly use the FibroScan. And if again in that, if the score is less than 8, I would still manage the patient myself. If the score is more than 8 and specifically more than 12, then obviously that indicates advanced fibrosis, and that means the patient needs further screening for NASH as well as fibrosis or even cirrhosis. So this is the step where obviously hepatology or gastroenterology referral would be needed.
So what you're saying is you will be doing the FibroScan yourself or getting the risk stratification yourself before you send them to the GI?
Yes.
And at that point, Dr. Rohit, what would be your strategy? What would you like to do?
So there are two aspects to this. So a patient with NASH who is coming to me, one would like to screen for two things. One, the inflammation, and second, the fibrosis. So for inflammation part, generally you look at the transaminases levels. Liver biopsies are the gold standard, but no one is doing as of now. And unfortunately, there are no definite non-invasive tests which can accurately predict the inflammation in the liver. So one has to basically rely on, in clinical practice, on the transaminases levels and take them as a surrogate marker of inflammation. For fibrosis, now we have non-invasive markers which can be biochemical markers, and we have scores like NFS, we have APRI, so one can use one of these non-invasive things. So FIB4, NFS or APRI. So these can be used as screening tools. Second step is to go ahead with the FibroScan, and if FibroScan values are high and non-invasive markers are high, then one can almost be sure that yes, this patient is likely to have a significant fibrosis. If there is a discordance, then one may again resort to liver biopsy to make the things clear. So why this information is important to us is because steatosis, bland steatosis is generally not related to adverse liver related outcomes. However, inflammation is the thing that one has to look for, because it is associated with a progressive liver disease. It is likely to be associated with a poorer outcomes in the long run. And even non-liver related outcomes are worse in people with inflammation compared to people with bland steatosis. So the evaluation is based on presence of inflammation and fibrosis and their extent, and then one has to take a decision regarding the need for pharmacotherapy and possible liver biopsy.
That's great. Thank you so much. I think we're going to go over some slides to cover a few topics, and then we'll have some more questions. I think some of these questions have been already covered. We've already touched base on who should be screened. Pathophysiology, I think it's our diet. Most of the complications that we are seeing these days are as a result of Western diet that we've all adapted in Indian lifestyle as well. High calorie diet, excess saturated fat, high fructose intake, sedentary lifestyle, all that is progressing to obesity and NAFLD. Unhealthy lifestyle plays a role in development of progression of NAFLD. The assessment of dietary and physical activity habits is a part of comprehensive NAFLD screening. There's some genetic markers as well that are not recommended at this time. It's not in any guidelines, but we know there's certain genetic markers. If people have those, they have more risk of progressing to advanced liver disease. Genotyping may be considered in selected patients and the clinical studies, but is not recommended routinely. We've already talked about the non-invasive studies, so we'll pass this. So let's talk about common related metabolic disorders. Dr. Farooqi, would you like to address that? What kind of metabolic complications can we expect from patients who have diabetes and elevated transaminases?
So I think one of the most common consideration is the presence of associated cardiovascular disease. So it can be present there independent of diabetes, and obviously it can be there even if the person has both diabetes and non-alcoholic fatty liver disease. The reason why it is important is that these are associated with long-term complications. So even though if we expect that this person can progress to in severity in terms of liver disease, but he might get affected by cardiovascular disease a lot earlier. So screening for and managing cardiovascular disease is of utmost importance here.
Are there any particular studies that you would consider in that case?
So that would be routine evaluation for the cardiovascular risk factors. We have to consider the historical references, presence of dyslipidemia, hypertension, or smoking history, alcohol intake, as well as the obesity. So all these parameters basically have to be reassessed, and then obviously if there is, it shows high, you can use risk calculators as such. Obviously, if it is on a higher side, you have to initiate lifestyle modification. You have to initiate statins if needed, and even go for additional, like even blood thinners if they are indicated. So obviously, it has to be done at the early stage so that we get the benefit in future.
Sounds good. Thank you so much. So the common related metabolic disorders is insulin resistance in the liver as well as in the adipose tissues and muscle tissue. Metabolic syndrome has, of course, for this audience, this is nothing new, but it entails impaired fasting glucose or type 2 diabetes with hypertriglyceridemia, low HDL, increased waist circumference, and high blood pressure. So all the components of metabolic syndrome correlate with the liver fat content. Evaluate the risk of NAFLD in patients with metabolic syndrome, and evaluate the metabolic syndrome in patients with NAFLD. So we need to do both in the reverse order as well. In individuals with diabetes, we could use the HOMA-IR for insulin resistance as a surrogate for insulin resistance. BMI and waist circumference are positively related to NAFLD, predictors of advanced disease, particularly in the elderly. Irrespective of the liver enzymes, diabetes risk and type 2 diabetes are closely associated with severity of NAFLD, progression to NASH, presence of advanced fibrosis, and development of HCC. So in individuals with NAFLD, screening for diabetes is mandatory by fasting or random blood glucose or A1C, and look for NAFLD in patients with type 2 diabetes, irrespective of the liver enzymes due to high risk of disease progression. So next question I have is for Dr. Rohit. If you have elevated transaminases, what are we projecting? What kind of natural history am I looking at?
So in patients with NASH, generally the major causes of mortality, I'll explain why I'm saying that, are cardiovascular disease number 1, cancers number 2, and liver disease number 3. Okay, so liver disease is still not the commonest cause of mortality in these patients, but yes, it is one of the top 3 causes of mortality. So only 10% of people are expected to progress to advanced fibrosis if they have NASH. But the progression is unpredictable, and it is also related to the status of comorbidities including diabetes and obesity. So to arrest progression, what we are attempting to do is to correct the metabolic syndrome, and that is the only intervention that actually has been shown unequivocally to help these patients. So lifestyle modifications continue to be the mainstay of treatment, and they continue to be the most effective treatment. A weight loss of more than 5% or more than 7% has been shown to improve inflammation. Weight loss of more than 10% at least is required to reverse the fibrosis, if at all. Secondly, exercise again has been shown in association with weight loss to improve the steatosis and possibly fibrosis, though evidence regarding fibrosis is not very clear. So treating the metabolic syndrome is the only way to alter the natural history, and patients with NASH tend to have a more adverse liver related outcomes as compared to patients without NASH. So this is the implication of NASH in the setting of diabetes.
Excellent. Thank you so much for that. I think I'm going to go through some of the slides a little bit faster for the sake of time. The prevalence and incidence of cardiovascular disease is higher in NAFLD than in the matched controls. And it's driven by association between NAFLD with metabolic syndrome. Cardiovascular disease should be identified as an NAFLD regardless of the traditional risk factors. Cardiovascular disease and metabolic risk factors are also reported in adolescents and children with so much of childhood obesity that we are seeing these days. Screening of cardiovascular system is mandatory in all individuals with NAFLD because of cardiovascular complication frequently dictate the outcome. So without going further into this such a busy slide, basically the message we were trying to get to was this multi-prong approach that we have to use to target on the inflammation and the metabolic syndrome, and to prevent thrombosis and the other expected metabolic complications that you can expect from this condition. So the cumulative incidence of NAFLD-associated hepatocellular carcinoma varies according to the study population. Let's go to treatment now. Treatment of NAFLD in the setting of metabolic syndrome. And now I have a question for Dr. Farooqi. We have so many new classes of agents that are available to treat diabetes and metabolic syndrome. Could you please enlighten us what would be your choice?
Yeah. So number one would be, as Dr. Rohit mentioned, would be lifestyle modification, because weight loss is something which has always shown a positive response. Now, in terms of patients with diabetes, obviously the newer groups, first and the foremost evidence was from pioglitazone. So multiple trials have shown pioglitazone to be beneficial in terms of resolution of the inflammation and some degree of fibrosis as well. Obviously, it can be used in the appropriate setting. We have to take care in terms of consider weight gain associated with this, like if the patient is postmenopausal or at risk of fracture, again, we have to take into account that as well. But this drug has shown a lot of improvement in terms of both steatosis as well as fibrosis. The other group also which has shown positive benefit is the GLP-1 receptor agonist. And we have seen it with liraglutide. Like apart from weight reduction, there has been some reduction in the liver enzymes, steatosis, and not much in terms of resolution of the fibrosis. So it has varied in trials. Our own experience with dulaglutide also showed that there was a significant reduction in terms of the liver fat and some reduction in the GGT. Now, the newer molecule, that is the semaglutide, that has shown again a lot of positive response, again in terms of weight loss and resolution of both the inflammation, and some degree of fibrosis reduction has also been shown. And the most recent one, you could say, the dual GLP and GIP-1, that is tirzepatide. So in the recent SURPASS trial, one of the subgroup analysis has shown benefit in terms of both steatosis reduction as well as in terms of reduction in the fibrosis. So three broad groups would be obviously PPR gamma agonists, the GLP-1 receptor agonists, and in SGLT2 inhibitors also have shown some improvement, but they are mostly in terms of steatosis resolution, and it has differed in terms of reduction in the liver enzymes. Effect on fibrosis is not much. So these three broad groups basically.
Thank you so much. That was very well explained. I'll just share my experience from my practice in California. We're using a lot of semaglutide in our practice. It has come under different names. There are 3 semas that are out there, and I often say I'm not sure why we have 3, but because they all end up doing the same thing. So first one we were using was Ozempic, which is the once a week. Then we got Ribelsis, and that is oral semaglutide, the only oral available. Is that available here, by the way?
Yeah.
Yes, good. Excellent tolerance and very good results. I mean, even though 3 milligram is considered to be not a therapeutic dose, 7 and 14 are the therapeutic doses. I have few patients in my practice who have excellent weight loss with even 3, so early stages. So the idea for metabolic syndrome and obesity and spectrum of conditions that we're talking about is let's treat it early before we fibrose the liver so that we can just cut it on the inflammation or either prevent it. And the third one that just recently came out was Wegovy, and Wegovy is the weight loss indication for obesity for semaglutide. Unfortunately, I think there was some manufacturing problems, so I was not getting enough supply, but we're using a lot of semaglutide in our practice and with a lot of success. So thank you so much for adding that. I think we are getting short on time, but we still have 2.5 minutes. What do you think is the role of diet and lifestyle? I would ask Dr. Rohit first.
So, as I told earlier, so this is the only treatment which has actually shown some benefit. So in a non-diabetic NASH, in a diabetic NASH, this is the treatment of choice, and this has to be done. So dietary modification and lifestyle modification has to be emphasized on every visit, and I think the involvement of gastroenterologist partly is to emphasize that particular point to the patient, because whatever therapies are there in the pipeline, none of them has shown actually a benefit which is more than that of the lifestyle modification and diet.
Dr. Farooqi, do you want to add anything?
Yeah, so what is important here is to emphasize that even if a person is not losing weight, exercising is still important, because you still have benefits that even without weight loss also, there is a reduction in the intrahepatic triglycerides. So obviously exercise needs to be continued, and weight loss shouldn't be our only marker of success of an exercise regimen. So, again, it's a graded response. If you are able to achieve somewhat of upwards of 10% reduction, obviously you will have some reduction in fibrosis as well. Otherwise, steatosis reduction does definitely happen when it is between 5 to 10%.
Thank you so much. I'll just add a brief few lines. I had a weight loss practice a few years ago, and it was very successful. I was so happy with that because all the patients that I was offering a structured lifestyle program were losing weight, getting off of insulin, getting off of medications, and they were very happy with less amount of copay or amount of medication money they had to spend on monthly basis. Plus they were lighter. Plus they were feeling so much better on their knees and everything. It's all worth it. If you can have a practice where you can have one day or once a week some weight loss efforts that can be included, that will be all worth it because it goes a long way for the patients as well. But most patients are looking for somebody to hold their hand, somebody who can help them coach and be their partner. So with this, I think we should come to the end. I'm going to stay on time. So no drugs are approved for NASH at this time. No specific therapy can be recommended. Any drug use that has been done is off-label for NASH. But what we talked about, GLP and SGLT2s and the others earlier, were all part of treating diabetes or advanced metabolic syndrome. So with this, I think I would say we should call it up. Thank you so much for your attention, and we'll stay on time. It's been a pleasure to share the stage with Dr. Farooqi and Dr. Rohit. Thank you so much.
Thank you.
Thank you, ma'am. Thank you all, three of our distinguished faculty, for the really interesting and engaging session. We truly had lots to learn. Can we have few questions, if there are any?
Sir, my questions to you people is, sir, at what level of transaminases do you recommend therapy?
See, it is not only the transaminases levels, it is the fibrosis also. So generally, if the fibrosis is not at all there, then so what therapy are we talking about is the question. So if it is up to 2, so what I do generally is up to 80 ALT, I generally will recommend weight loss and lifestyle modification and follow up the patient for 3 to 6 months if the fibrosis is not there. If the fibrosis is there, then also I will do the same, but generally I do consider adding vitamin E or obeticholic acid in the patient. So after discussing with the patients, I tell them that yes, this might help, but again you will have to rely on weight loss and lifestyle modifications because that remains the primary therapy. Okay, and if a patient is diabetic, then the diabetic medications are to be modified. So like it has been discussed, so one has to consider switching to other drugs like SGLT2 inhibitors or glucagon-like peptide drugs, because they might further improve the liver condition also.